I'll invite my panelists up and let's start the questions. My questions, not your questions. I'll ask first and then everyone else can ask in a sec. And we have an upstairs view. And we have one more panelist. So Michelle has joined us. She's going to give us an interesting perspective as a founder in the industry who is kind of coming at this from, the other direction and, the challenges and experiences and opportunities that she's been facing. Hello. Are you still with me? Oh, it's a long day, isn't it? Like, honestly. Okay, so I'm not going to. Well, I have a couple of questions, but none of them. They're all canned. I'm not going to lie. Tam, I know I've been joking about the E's, but like, you spoke about the E's, the 4 E's, but you didn't really delve into them. I'd love you to delve into them a little bit more and just kind of really explore that framework and how it can be effectively implemented. Maybe in the public system, maybe at the primary care level. Can you take us a bit through that?
Thank you for that, and also invite the panelists to join as well, because I think between us, we've got plenty of experience, and let me share with you sort of how I come up with the 4 E's, and now it's going to be, my goodness, at the end of today, it's going to be 20 E's, right? So, but I really started out looking at digital health transformation, AI, and so on and so forth, and everyone was talking about efficiency, and I said, well, it's almost like the metrics that, we all know, the classic sort of MBA class where as part of the KPI, you've got to pick up the phone within 2 seconds when it rings. And someone pick up the phone and say, can you hold on the line, and put the phone down. So that's that. You meet the metrics, but everyone getting angrier, Or the same thing as, length of stage. We've got to reduce that 2.5 days to 1.5, and that's great, we made it, and then you don't look at the readmission rate, right? So then I look at a bit further in details, like efficiency at what cost? And I think this is where, when it comes to, and to me, in healthcare or in project management or in startup or in whatever space you're in, you got the 3 variable: time, quality, and cost. Now you can afford to, push things to do quicker, cheaper, but not at a lower quality. And I think that's where the efficiency looking at in terms of, and out of that quality it comes with the experience. And then, so initially, I was thinking of equity of access. Oh, we've got everyone to get access. But it comes back to outcome. And it's hard to measure, and actually costs a fair bit as well, and hence the economics. So in terms of really, and how I sort of use that framework, as I said, 6 or 7 years now, in all the thing I do, and I'm glad that there's other E's as well come along with that. But underlying that is the PESTLE framework, where you got to look at different aspects, the political, the environment, the ethics side of things, the legal framework. We all know in technology in particular, the legal framework is always going to be behind all of the technological advancement, but that does not mean that we should be stopping. And so that's sort of been my mantra, and so in terms of whatever I do, and in terms of looking at that experience, that equity outcome for everyone. So I'm going to stop there and invite other panelists to add their experience as well to that.
Thanks, Tam. Michelle, hello. Hello. Welcome. You've got to use your mic.
Hello.
Otherwise, people who are online can't hear us. So I don't have an E for you. I'm sorry. Not yet. I'll have to wait until after you speak. But, you've obviously come at this from the other perspective. You've implemented AI clinically and across the globe, right? So not just in Australia. And I'm just curious to know what you see are the biggest barriers to adoption that you'd like to share, and maybe, you know, the folks in the audience can learn from some of your challenges?
Sure. I feel compelled to add another E, though. Maybe entrepreneurship. Let's add the other E. No, it's there's a lot of barriers. I think we were talking over the lunch break in a couple of conversations I was having, and even we touched on it in the previous panel. You know, this is healthcare, and technology is a really complex area, and trying to bring products into clinical care is really complex. And then trying to do that at global scale, which is what you want to do with AI, because AI knows no borders. The whole benefit of it is that it's scalable and you can implement it globally, is really challenging. So there's a lot of barriers. There's, you know, regulatory barriers. We're in 48 countries. We've got to deal with regulators all around the world. In one country, we're not a medical device. In another country, we're a class 1. In another country, we're a class 2. In another country, we're a class 3. In the US, you know, if you take an image of an embryo and use AI to analyse it, you need to do a $3 million multi-centre RCT trial on more patients than they tested the COVID vaccine. But you can cut out part of the developing embryo and do genetic testing on it, and that's not regulated. So there's a lot of complexities within different clinical areas, and I guess the challenge for, you know, we're having conversations about why there are all these papers around, you know, this brilliant technology that can actually change clinical outcomes, but those technologies never see the light of day and don't get implemented. The reason is because it's difficult, it's expensive, it takes time. Investors aren't patient. They don't like to, private capital doesn't like to wait for those outcomes. And I think one of the biggest problems that we've seen that I never really envisaged is, it sounds crazy saying it now, but someone has to pay for it, right? You've got all of these AI products which are sort of point solutions for a particular industry, but all of those point solutions have to survive in their own right, and someone has to pay for it. And then you get into this situation where you're trying to analyse the value of that AI, and is it discretionary, or, you know, trying to do their health economics on something that you can't implement is incredibly difficult, so you can't get reimbursement. So it's just, I think the adoption barriers are around the business model of how you know, how you position the product to create efficiency or improve outcomes to the extent that it fits and aligns with the incentive of that sort of clinical practice that you're trying to implement into. So it's incredibly difficult. I don't think we're going to solve that today, but there are a lot of barriers to adoption that need to be solved.
Thank you, Michelle. Does anyone have anything that they wanted to add onto Michelle's topic? Or if not, I'm going to ask Emily a question. Do you, Brett?
Just to add my public health E, which is impact, and maybe I need a New Zealand accent for that, impact, because beyond efficiency there is that outcome at a population level that that we're all wanting to achieve, and it's really healthy years of life lived. That doesn't happen just in the healthcare provision space, it happens at the deep preventative level, and I think the application of AI for population health is even trickier, because you've got really profound barriers about the indirect pathways and the long latency period for impact, and you basically have to make a case to government as the funder of those interventions. But I think the opportunity there for creating years of healthy living is really profound, but it goes to the deep data analytics that relate to nutrition and sedentary behaviour and overweight and obesity and risk factors for disease, rather than an interrogation of disease management at the clinical interface. So I think we need a kind of testing ground at a policy level, or some of the deep insights that we can get with ABS data, AHW data, but we do need AI in a box to be able to manage individual patient information in a secure way that isn't given over to Google completely.
And just to add to that quickly, I know you're going to ask the same question to Emily, but I think that impact, you know, I spoke about the 10% GDP, how much of that is actually in the preventative public health. and to someone like Brett, who's a public health person, that's music to his ear. But we really need to try to change that, because otherwise we tend to be treating the issues really late on down the track, as opposed to the upstream part where I think it takes time. It's hard to demonstrate that, and I think we've got to be smarter in terms of that. And what Brett touching on about kind of that quality of life as well. You know, we always say, it's a book I'm reading at the moment, it's called Outlive, and it's talking about longevity and so on and so forth, but it's actually, longevity's been around for like centuries, you know. So people talk about it, but it's actually, you live longer, but is it a quality of life and so on and so forth? And really interested to hear from Emily's view about sort of how we're coming in with that public-private partnership, and as you've done, you know, it's sorry, actually, I should hand that back to that. You should be doing the modelling. Sorry.
Tam's gone straight into facilitator mode. You couldn't help yourself, could you? I was like,
it's a bit like ChatGPT taking over now.
Tam pilot. Emily. So, I mean, yes, you know, I've given you another E, which is ecosystem. You've added another E, which is entrepreneurialism. You know, the partnering and, you know, us trying to do things in isolation is never going to work, right? We have to partner, and we need to figure out better ways to do that. So my question to you is, you know, where are the challenges that you've noticed with governing public-private partnerships, and, you know, how then have you been able to overcome that to grow efficiencies and capability with AI?
Thank you both for the question. Look, it's a really interesting point, because in healthcare we know we have to leverage our partnerships. It's the way that we can achieve great outcomes for our patients, is the fact that there's so much shared knowledge and resources available. Where we've sort of seen this, and particularly in my role within the Calvary Ampler joint venture, is we've been able to leverage ourselves then as that key private player, where we have virtual hospital technology then that can leverage then into the public health system to rapidly scale up. And outpatients and elective surgery are probably the two areas which are really, you know, are just not getting the attention they deserve currently within the healthcare system. We know that public-private partnership in this space can have dramatic transformation. So not only can you transform in terms of your waitlist times by shifting in relationships, then moving the patient across into the private healthcare system, leveraging the bed capacity that's available, but we can actually front-end that through using the technology to be able to understand where that patient is best to receive that care. So we know if we look through the data, we run the analytics, and we can then screen patients more thoroughly prior to coming in for that initial outpatient appointment. We can then identify whether that patient is actually going to be a low-risk surgery that can be performed safely within the private sector. We know they can receive their surgery earlier if they can then go across into the private sector. They can then have the follow-up in the private sector, and then we've supported that patient, taken that patient out of the public wait list, and freeing up that bed then for someone who has more complex care needs that requires that more multidisciplinary, longer stay focus within the public health system. So from a Triple P perspective, there's a lot of opportunity here, and we have been able to do this through our own structured governance models. We're very agile in what we do. We can set ourselves up in a way whereby we write our own rules, essentially. You know, apart from the TGA governance and the regulatory side and what sits behind the Privacy Act, we're very clear that we can set up our own structured governance model in the fact that we bring on board the experts, we leverage across our knowledge and expertise, and then we partner in the public system so that we meet their requirements. So every step we do, there's always a dual review of everything we do. So it happens within the private system, and then we mirror then what is required in the public system if they have that particular committee or governance set up. And what we have found is there's just not the governance in place. And so it means that it's up to us then to set up and say, well, this is how it needs to be. And they go, oh, that's fantastic. You know, we just didn't realise the complexity here. Now, I think that tells you why we have to partner and why we need to have shared learnings here. And it's not about a commercial relationship. And I think that's the challenge here, is people think, you know, it's Triple P, it's about the commercials, it's about the profit, it's the margin. It's not. It's about the shared understanding and the fact that we've done things differently. We've got a lot that we can then bring into the public system to enhance the care. And I was just thinking about your point, Brett, that you made around what we're doing more broadly around the healthy years. It was World Kidney Day last week. Renal disease is one of the biggest issues that we're facing as a silent killer. And as part of the launch last week of the 5th guidelines that have now come out for primary care, it was talking around, the importance of reminding GPs to screen for urine. Well, why are we relying on a PDF paper document to remind GPs to screen and perform, urine albumins? That should not be the way that we are screening for the silent killer. So I think there's a lot we can be doing around leveraging what we know, and I think there's plenty of opportunity in the public health space.
Awesome. Thank you. Clear that you're committed deeply into this concept of working in partnership. I'm going to go to you, Brett. You mentioned earlier, about having an AI in a box. I think about that from the Microsoft perspective. How can we have, set up a clinic in a box, or a X in a box? Not X, obviously Twitter. That's not that. But whatever it happens to be in a box. Jack in the box, maybe for me.
Xbox from Microsoft.
Yeah. No. But so I'm not familiar with the Gen V study, right? Maybe if you could just sort of take us through that very briefly in terms of the data sets that you were able to get, and then how does that translate into AI in a box? What does that look like?
Yeah, look, I haven't been involved in the Gen V study myself, but it's a population-based cohort that's been followed for a number of years, includes children, has the bioinformatics of blood samples that can then be matched with all of the socio-demographic and other health data for that enormous cohort. And so it's the kind of fantastically rich information that you want to be able to delve into with all of the potential insights that it could provide. And I think it's not unique in that sense. There are multiple biobanks around Australia and globally. The Global Biobank Consortium is seeking to make sure that that's a sustainable system that can always be accessed, because they're such valuable resources to interrogate. But the insights that can be made from that are the kind of things that go to invisible killers. When you find out that, look, here's a biomarker that has a lead time of 5 years in terms of being able to flag clinical illness. You probably need AI to bring together the various biomarkers that can tell you what combination of things is raising a red flag. But those are the kind of profoundly valuable collections that should be available for interrogation. The issues with potentially individually identifiable data for patients is that this is our most sensitive information. And so we're not going to give it over to AI that is potentially controlled by others, or that might be on-sold, or that might be hacked, or that doesn't have sufficient cybersecurity that gives us the confidence of giving over our data in that space. So I think AI in a box that can be held with a trusted organisation, and it might be government, it might be, a quasi-autonomous agency like CSIRO, that can interrogate that, provide the insights without that data being compromised in any way. And so I think whether it's Gen V or any other big population data set with good bioinformatics, let's make sure that we can interrogate it in a way that doesn't lose trust of the individuals who are the precious contributors to that over time.
Thank you. I have another question for you, Brett. So you mentioned, big companies or big entities that could, help control or manage the data. And I don't know if she's still here, Robin from the TGA, but I'm curious to understand what you feel is an appropriate sort of innovation model for AI in healthcare, and whether or not the TGA or other bodies like that need to be involved.
It's a tricky question. It's not my area of expertise, but I think, look, there's a double-edged sword here, isn't there? The TGA has gotten Australia into a place where there is enormous trust in the medical products that come out in Australia because of the very robust regulatory system that sits over it. And so whether it's a vaccine or a new drug or a new medical device, there's a great deal of trust that has global benefit for international use. because of that robust regulatory oversight, the dark side of that, or the flip side of that, is that there can be long periods of time before there's approval processes. And so I think there's absolutely a role to play to make sure that that trust is maintained for the AI tools that might be in place in a clinical or health setting. At the same time, the TGA needs to make sure that it is mobilising the community of, you know, the hive mind that's in this room and across Australia to be able to provide some of the technical guidance about how the regulatory framework might look. Because I don't think the TGA can do that in-house. I think the TGA needs to put its hand up and say, look, we're ready to put this into a framework, ready to have it reflected in regulatory policy, but please do the work for us because we are not the ones who are using it every day, and we are not the ones who've got the deep insights into the issues at play that the TGA will need to consider. So I think it absolutely has a role to play, but we need to help it on its journey.
Awesome. I'm going to actually go to the audience just to see if there's any audience participation.
I'll just add a quick point to Brett in terms of, and we go to the audience for questions, but definitely we all got to play our part and you know, supporting the TGA. Often we say we'll look to government, TGA and so on and so forth. There are different groups out there, and I think, you know, for example, AusBiotech and the MedTech group, you know, looking at this, the Institute of Machine Learning, there's the AI and Healthcare Alliance Network, and don't forget the patient as well, the community. And I think, you know, Sam Freeman, who finished his PhD, and I had a pleasure of co-supervising him, and he looked at, I guess, the perspective of AI implementation in healthcare, from primary health network to tertiary setting. And you'd be surprised, you know, there are groups out there, and in terms of really getting that support and feedback from the community, I think that's important. And I think the buy-in and the thing that we've been talking about in terms of adoption, definitely we need that buy-in from the community as well.
Thanks, Tam. I know it's late in the day and everyone looks a little tired. Oh, we have one question here, then we'll have a second one there.
Gehan, I'm a GP. I have a question, particularly in relation to what Emily was talking about before, from partnerships point of view, particularly public and private hospital partnerships. What we see in general practice as a huge barrier is the funding dichotomy between state and federal funded health systems, particularly general practice being largely federally funded and having difficulty communicating with state funded organizations such as the local hospital networks and so on. Now, this is a funding level barrier, but also from regulatory point of view, I can imagine lots of barriers being put forward, particularly from AI and its rollout point of view as well. What are your thoughts on that?
Yeah, it's a great question. I think let's start with unpacking around what's already working well within general practice and primary care. We know there's already been investment coming, and particularly we're going to see more and more rolled out through the medical software organisations, and where there's been, you know, embedding particular ways that we use. I think you referenced Doctors Control Panel as well. You know, that's it's ways that we've seen things done differently in general practice, where it's actually ahead of where the tertiary hospitals are sitting, and we've seen that with the EMR being in place for a number of decades now within general practice, and it's mainstream. It's mainstream that I don't know any GPs who are using paper-based notes, and that comes then to the funding point around. We know that the challenges that we have, and the National Health Reform Agreement is not being then, you know, till 2025, where we're going to see those new changes potentially. We've got My Medicare coming out later this year. I'm not seeing really the investment that we need to have from a digital health perspective. You know, it's a key enabler around how do we then deliver care better for our patients is by having the connectivity piece and the interoperability between the tertiary and the primary care system. And so where the Triple P comes into this space, which comes back to your question, is that there's so much we can be doing and partnering from a state health perspective that can then benefit general practice and primary care. And certainly, you know, my previous role one stage I was the Executive Director of Community and Primary Care Partnerships within the department. And at that point in time, we were looking at, establishing agreements with the primary health networks. Where could we get them to utilise their funding and commissioning money better to support our health system? Because there's some really good pockets of funding. We've seen Hunter New England announced around their new pathways and investment they're doing with the PHN last week, that there's a lot of opportunities we can be doing differently. So, I think it comes back to where the PHN, the state health, and then when we partner across into those private organisations, that there's a lot of opportunity there that's often untapped. But, I must say, you're doing amazing work within your practice and the work you've done with Next Practice. There are so many opportunities out there within general practice where we can do things differently and better for our patients. And I believe, around scope of practice conversations, we talk about all the investment that's now happening with, particularly around the practice nurse role and where we see nurse practitioner roles, but I'm not hearing the investment happening within the technology infrastructure required for general practices to be able to elevate care to where it needs to be.
Can I just ask a question? I'm going to go rogue and ask Emily a question myself. But it seems like everything we're talking about is kind of whose problem is it to solve, right? Like, we all know the problems. The patients want better outcomes. The clinicians want better, infrastructure and tools and need funding to implement. And, no one wants to pay for it. Where's the investment coming from? Because it seems like there's this big lag in kind of infrastructure investment, not physical bricks and mortar infrastructure, but the infrastructure to be able to deliver digital technologies into this sector is kind of where it's, where does that funding come from? Surely government.
Yeah, and I think this is the challenge. Around where we see the NHRA, the challenge with the Commonwealth and the states. I truly believe it has to be joint ownership and responsibility. And the problem that we have with primary care and where we're seeing the community is that then we've got the aged care sector, which is Commonwealth funded. So we get into this difficult space then between what we're doing from a state health perspective. And so certainly, the primary care pilots, the initiatives announced through the Commonwealth and state to jointly fund projects was meant to help bridge that. I don't believe that has had any impact at all in this particular space. It's been around workforce and focusing on scope of practice, nurse practitioner models. We've invested in Health Direct, but it'd be great to see clear outlines. And I think that's why you need organisations and groups coming together like this, where you're actually very clear in the position to the Commonwealth that it has to be a shared responsibility because we all benefit from this. It's not like only one side of us benefits. Every single person benefits through investment in this space. There's no one who loses out of this. And so we have to come back to what does the consumer need. They need better coordinated interoperability for their care.
Brett, I saw you had your, no, you're good, okay. Thank you, that's great. Did you still have a question? Yes?
I'll read the TGA. I know they're not here anymore, but they do want to be collaborative. I've taken them personally myself out to visit a number of, not necessarily AI, but Industry 4 type companies with their TGA hat off, and they definitely want to be involved in this. So there's TGA hat off and TGA hat on, and they're very happy to talk to you with the hat off to learn more about this because they don't have the answers. And I'm putting together a big Industry 4 forum coming up later on this year, and the TGA are going to be involved in that, and it's going to be totally collaborative between all the groups and the states and everything, so I'll tell you more about that later on. But that wasn't really what I wanted to ask you about. We've heard a lot today about AI, and AI, as you know, the whole process is like a big jigsaw puzzle, and there's lots of pieces in it. And AI is a few pieces in the jigsaw puzzle, but that's not the starting point. It's a little bit down the track. The starting point is know your process. And so my question was really to Emily, about the project you're doing with the ramping of the ambulances. Did you initially do like a process mining exercise where you went back and, because that's a really good starting point to use your data to do a backward reverse engineering to find where your pain points are, find where the bottlenecks are, and then implement AI, robotics, drones, whatever it is. But don't go and try jackhammer a piece of technology or an AI into your facility before you know your process, because it's really the key is your process.
Yes, I think from reflecting, and I'll reflect on Johann's points as well that he raised earlier around the work that we've been doing in SA and particularly around our data lake, and it sits across both SA and the Northern Territory, where we have immense data capability within our state that we can very quickly identify where the issues are in terms of the system bed block. And there's been a lot of data to inform where we have then invested money. And I think that's part of the reason that we have been slow to adopt has been the fact that we've taken our time to work out where those problems lie. We've worked out really that, we can focus on the ED because that's visible for patients. It's front page news, is the ambulances ramping. It's the incredibly sad stories of when ambulances can't respond to patients in the community. So from a political perspective, it's incredibly important that we focus on how the emergency departments operate and ensuring that consumers can get that really acute care when they need. But what the data is telling us is, in fact, it's the back of house. We know it's back of house. It's the issues around general medicine patients whereby they're admitted into the hospital and then we start these incredibly long, comprehensive testing regimes for patients who simply don't need that level of testing. And it comes into a whole value-based healthcare discussion. That's what the data is telling us. So if we can get this right in terms of small-scale implementation within the ED, where we know there's a problem, there is so much opportunity then much broader across the health system where we can apply these learnings. And just a point for reflection, one of the pieces of work we did last year was to run an algorithm across, because we're very fortunate in SA having the one EMR system, was we ran an algorithm across the EMR which identified which patients could receive care within an alternative location. So it was either hospital and the home services, a virtual hospital, or going to a priority care centre or urgent care centre, as they were previously called. And what we found was there was about 30% of patients in hospital beds who could be seen within community-based services. Now, that was dramatic. Now, you would think that that data would then help to influence and change outcomes, but unfortunately, it hasn't seen a transaction. But what we've been able to do is demonstrate through that algorithm was, in fact, that's a great starting point where we can then have AI come in and then have predictive work that sits over the top of that. So we've already started to get a little bit of change with clinicians, but the ED has been our focus because that's where we had the biggest engagement and we see the greatest wins in the short term.
Thanks, Emily. We have one question here, and then I'll go to you. Thanks.
Sorry, I think you answered my question. I mean, the one thing, I'm a GP, or I was a GP, so you've got a problem with basically ambulances ramping at the casualty department. My question would be, what do those patients have? Why are they there in the first place? Do they need to be there? Could they be seen by somebody else? Could they be actually... As an example, I had a practice in Burwood, which I've mentioned this to someone, and we had 7-day-a-week x-rays, right? So basically we're able to... And we had people who were trained in fractures and whatever. So we approached the local hospital and we said, look, why don't we just take your overflow, which would actually be commercially wonderful for me because it means that I could employ and pay people for doing value-added work. So rather than actually get a patient to wait for 6 or 8 hours in casualty, send them to us, we'll do the x-ray. If it's a compound fracture, we'll send it back to you. But if it's a simple thing like a green stick, and invariably it was, we can handle that. We've got a dressing room, whatever. It never happened. They would do it for a week and then someone would basically say, well, no, we can't do that because we're actually sending patients to a private facility where, in fact, they will be funding, et cetera, and they're only doing it for the money. So, I mean, realistically, if there's an issue with ramping, I would have thought the first thing to do would be to, and I'm sure you actually do have the information now, obviously. That's the answer, isn't it? Is, in fact, it's not to necessarily fix the casualty problem or the admission problem, it's getting to the patient before he actually gets to casualty.
And I think there's some incredible data that's sitting out the system that shows us around readmission rates, preventative hospital presentations, that shows us that data is sitting within general practice, that we can be, if we can support GPs around, particularly around the care management of those patients, linking into outpatient clinics virtually, not requiring patients to come in EDs, there's such a big difference. But what you've highlighted there is the challenges we have within a bureaucratic healthcare system. It is a challenge to get these partnerships off the ground. There's procurement challenges. I've seen this many times in my previous roles in the department, was there'd be some amazing initiatives and, incredibly dedicated GPs who would come with this model, worked out, one was example, GPs visiting aged care facilities where, you've identified, it's a suitable patient can be seen by a GP. Now, we just could not get an agreement in place because of the procurement challenges. We'd have to go to tender, we'd have to say, this is what we want to do, we'd have to step it out in the scope. it's just incredibly bureaucratic. So what I guess I take from this is, moving forward, we have to be much more agile in terms of how we approach these challenging problems.
Bureaucratic. That was the very first point that Anton made at
Well,
the very beginning of the day, is that we have all this.
Just one sec, sorry, because no one can hear you online. So, but we might, just in the interest of time, because we have about 2 more minutes of audience. Sorry, maybe we'll address it at the drinks.
Happy for questions to come back offline.
What was maybe it's about reimbursement, perhaps?
You guessed it. Yeah, my name's Pete Saunders from Commercialise. So a lot of the discussion today around AI, around innovation, all these things, regulations comes up a lot, and that's good, and it really should, but reimbursement hasn't been discussed as much. We work with clients all around the world, and we're getting quite often to a point where we are telling international companies that Australia is not a very good setting for their innovation because reimbursement doesn't exist. So we're looking at novel MBS codes and all these sorts of things, but it's really challenging to have a go-to-market unless you have health insurance and out-of-pocket. Now, it's late in the day. This is a thought that's hopefully becoming a question. But if we are looking at innovation and we're looking at reimbursement, probably the biggest change that happened was COVID and telehealth. But everything's bucketed now into telehealth. You can go to America, you can get codes for remote monitoring and remote diagnostic and that kind of thing, but nothing happens in Australia. So the question I have, or maybe the challenge I put forward, is if we're going to do all of these things, which are essentially about improved patient care and patient access, you need to rethink the reimbursement models. You need to look at how reimbursement is going to accommodate natural language processing, machine learning, AI, all of these things. So the question for the panel is, how are we going to put pressure, and where's pressure going to come from in the regulatory bodies to open up reimbursement for these sorts of products, services, innovations, tools?
Awesome. Yeah, you. I'm going to give that to Michelle.
Yeah, I think you've raised an enormous issue, right? Regulatory is one thing, but who's going to pay for it is the other thing. And these innovations can't survive if they're not reimbursed. And a lot of, you can kind of palm it off in the short term to patient pays for some of these sort of extra services. But long term, that doesn't work because the patient shouldn't have to pay for everything out of pocket, and it should be reimbursed. But it is a problem in the US as well, where a lot of the reimbursement codes, just this type of technology just doesn't fit. Right. And the issue that we have here and elsewhere globally is when you're trying to, if you don't have an existing reimbursement code, it's a very long timeline, very costly process to get there. And even if there is a code, you need significant health economic data and in-use real-world clinical use data, and you can't get that unless there's adoption of the technology. And you can't do that for free unless someone pays for it. And so it's kind of this cyclical issue where there needs to be some focus on, if this thing is demonstrated to have clinical utility and it is to the benefit of the population base as a whole and to the benefit of the health system, then there needs to be some pathway for funding and getting that into the reimbursement system. And has happened kind of on small scale in Australia in some areas, but it's an incredibly big problem, and I just don't know how you solve it other than opening up those more flexible kind of reimbursement codes to account for innovative technologies that don't fit elsewhere.
Yeah, I was just going to add, I recognise the challenges, but I really encourage you to think about how in our ecosystem where we have a healthcare system where we do a lot of the clinical validation. And so, I work in the clinical trial space and a lot of companies come across, and part of that is being involved providing the expertise and some of the element of R&D tax incentive. And in the sort of health tech, medtech space, so remember though, we as a nation, 26 million people, it's a small, tiny market, and yet we actually can do a lot of when it comes to doing those clinical validation. In terms of kind of working with those startup and scale-up companies, we've got company coming across in the region from the like of Singapore, Indonesia, coming across and work with us. And so we've got to leverage on that as well, where it might not be immediate, but I think definitely, and it's also being involved in, I guess, changing that HTA, Health Technology Assessment Framework as well, how we can actually looking at from doing the validation, but also demonstrating the value. And I think what Emily touched on briefly before was on the value-based healthcare. I know it's big in the US, and we probably don't have time to talk about it, but I think that's important, where come back to that sort of 10% of GDP where we spend in healthcare, and perhaps that element of procurement and how we actually, use some of the project that we work on through that validation, that potentially means that if we get involved early, you get the buy-in, and then in returns you pay less a premium, because otherwise, if we don't do any of that innovation, solution will be going somewhere, and then we pay a high premium when it comes back.
Absolutely. Thanks, Tim. I'm just conscious of time, so it's 5:10, and we need to hear from David as well. So what I would recommend is that maybe if there's any more questions, and I know you guys have been super quiet the whole day, but maybe everyone's been swapping around. I don't know what's been happening, but perhaps come and grab one of us or all of us at the networking session. I'm just going to close up with some of my thoughts, and I think that there's a couple of things that I've seen throughout the day that are, nice threads for all of us. Although you might disagree with. I wrote down earlier, pause, plan, and observe. And you're obviously don't pause some things, but do pause, as in, just sit with the idea, think about it, and then prepare. It's another P. I'm going to get into my alliteration. Prepare your own data sets so that they're ready, right? So they're ready to go when you're ready to go. So that was one thing. Define your own guardrails as well. So yes, listening to everybody's, go with what the regulatory bodies are saying, but also define something that's most relevant for you and your organization, and then embed appropriate governance, because nothing is going to get done otherwise. And not just your typical people in the governance space, like more broadly, right? Bring everybody on the journey. Identify use cases that are easy, right? Some of the easy use cases that might seem not sexy, but they're actually going to change your clinicians' lives, or they're going to change your administrative staff's lives, and give them job satisfaction, and therefore maybe reduce burnout, and maybe has a flow-on effect thereon. And then finally, experiment and find a trusted partner. So I think we're here. I'd love to talk to anyone and everyone who's interested in having a conversation about commercializing an idea that they might have, or networking and giving you the contacts to speak to. Like, that's kind of the great thing about my job, is that I get to know loads of people. So I'd be happy to help make some introductions. But build trust and build a great, strong, solid partnership. Because we're not going to get there on our own. We have crossed the Rubicon, but now it's like, what are we going to do? Okay.
I love it. I think we crossed the 20E experiment was the last one. So.
Okay, thank you, everybody. And thank you to my esteemed colleagues and panelists. And David?
Okay,